Welcome to the deep dive. We all know that feeling of shock, right, in everyday life?
Oh, yeah.
That jolt of surprise or maybe dropping your phone, that sudden jarring thing.
Definitely.
But in the medical world, shock is something else entirely. Much bigger, much more, well, dangerous.
Absolutely. It's a whole different beast. It's not just a feeling, it's a systemic crisis,
Hmm.
a critical emergency.
And the tricky part, I guess, is that different kinds can look similar at first glance, like low blood pressure.
Exactly. That's the key. What seems like one problem on the surface could stem from totally different root causes. And knowing the difference is, well, it's life or death because the treatments are so different. Sometimes get completely opposite.
And that you is what we're diving into today. We're going to unpack medical shock. We'll look at the four main types, how they work, how they show up in the body, and crucially, why managing them requires such different approaches. All based on the sources we've got.
Yeah, by the time we're done, you should have a really solid, structured handle on it. We want to take this, potentially overwhelming topic and make it clear, maybe even spark a few aha moments along the way.
Okay, let's get into it. So, the absolute core of medical shock is what?
At its heart, it's the body's failure to get enough oxygen to the tissues. Simple as that sounds, it's profound. It's a breakdown in oxygen delivery.
Right. And usually we think low blood pressure, hypotension, but that's not the whole story.
Not always, no.
Yeah.
It's often there, but the real medical definition hinges on either low cardiac output, the heart's pumping power, or low systemic vascular resistance, how squeezed or relaxed the blood vessels are, or sometimes both are low.
Okay, SVR, systemic vascular resistance. Can you break that down a bit more? What is that, practically speaking?
Think of it like the friction or resistance the blood meets as it flows through all your blood vessels, especially the tiny ones way out in the periphery. If those vessels clamp down, constrict, SVR goes up.
Harder to push blood through?
Exactly. And if they relax, dilate, SVR goes down. Blood flows more easily.
And this leads to that fundamental equation, right? The one that unlocks everything.
Pretty much. Blood pressure equals cardiac output times systemic vascular resistance. BP equals COX SVR. Understanding that relationship is key to understanding all the shock types.
Okay, so keeping that formula in mind, let's talk about those four main types you mentioned. What are they?
Right. The sources lay out four distinct categories. First, there's hypovolemic shock.
Hypo meaning low, volemic meaning volume.
Spot on, low volume. Caused by losing blood, like in a hemorrhage or losing other body fluids, think severe dehydration.
Okay, then what?
Second is cardiogenic shock. This is purely a heart problem. The heart muscle itself is failing as a pump, maybe after a big heart attack. It can't generate enough cardiac output.
Makes sense. Cardio heart, alenogenic originating from.
Precisely. Third is obstructive shock. Here, something is physically blocking blood flow. Could be outside pressure on the heart, like fluid building up around it, or an internal blockage, like a massive clot in the lungs.
So the pump is okay, the volume might be okay, but there's a roadblock.
You got it. And finally, number four is distributive shock. This one's different. The volume might be okay, the heart might be pumping fine initially, but the blood flow is, well, distributed all wrong. The vessels lose their tone, blood pools in the wrong places, away from vital organs.
And that includes things like sepsis.
Exactly. Septic shock is the big one here, but also severe allergic reactions, anaphylaxis, and certain nerve injuries, neurogenic shock, even some endocrine issues.
Okay, four very different underlying problems. So what actually happens inside the body when any of these hit? The pathophysiology.
The common thread, again, is inadequate tissue perfusion. Cells aren't getting the oxygen they desperately need.
And without oxygen.
They can't make energy efficiently. They have to switch to this backup plan, anaerobic metabolism, which works, kinda, but it produces lactic acid as a waste product.
Lactate. That's why that gets measured, right?
That's exactly why. Rising lactate levels are a huge red flag. It tells you cells are oxygen starved, and it's a measure of how bad the shock state is. This buildup also causes metabolic acidosis, which is dangerous in itself.
But the body doesn't just give up, does it? It fights back.
Oh, absolutely. It kicks into high gear immediately. The autonomic nervous system sounds the alarm.
Fight or flight system.
Yep, the sympathetic nervous system ramps up big time. It triggers widespread vasoconstriction, tightening blood vessels to boost that SVR, and it makes the heart beat faster and harder to try and increase cardiac output. You get a surge of hormones like norepinephrine, dopamine, cortisol.
Trying to maintain pressure to the important bits. Brain, heart.
Exactly. It selectively clamps down blood flow to less critical areas, skin, gut, kidneys, to shunt what little flow there is to the brain and heart. It's a triage situation.
And there's another system involved too, RAAS.
Right, the renin-angiotensin-aldosterone system, that gets activated too. Its main job here is to make the body hang on to salt and water.
So stop peeing, basically.
Yeah.
To keep volume up.
Pretty much. Reduced urine output is a classic sign. And RAAS activation also contributes to more vasoconstriction. So the body's pulling out all the stops, hold on to fluid, squeeze the pipes, make the heart work harder.
It's an intense response, but if it's not enough or if the shock goes on too long, what then?
Then things start to break down at the cellular level. The cells run out of energy, ATP. Their internal machinery, like ion pumps, fails. They swell up, stop working properly, and eventually they die.
And metabolic acidosis just gets worse.
Keeps getting worse, yeah. More cell damage. And this damage isn't isolated. It starts to affect whole organ systems.
Which leads to MODS, multi-organ dysfunction syndrome.
Exactly. The lungs might fail, the kidneys shut down, the heart function worsens, the brain gets affected. You can even get widespread abnormal blood clotting called DIC. It's a cascade.
And if that continues?
If you can't reverse the shock state, it progresses to multisystemic organ failure, MSOF. And that's often the point of no return.
Okay, that's grim. So recognizing shock early is critical. What are the signs we should be looking for? What does someone in shock look like?
Generally, they look acutely ill, very sick. Often, their mental status is altered. They might be confused, agitated, or difficult to wake up.
And vital signs.
You'll often find their peripheral pulses are weak, maybe thready or even absent. Heart rate is usually fast, tachycardia. Skin typically feels cool, clammy, maybe looks pale or mottled, blotchy.
But you mentioned sometimes the skin can be warm.
Yeah, that's a key exception, particularly in early distributive shock, like sepsis. The widespread vasodilation can make the skin feel warm and flushed initially. It's confusing, but important.
What about blood pressure? Always low?
Usually low, systolic, typically under 110 millimol in Hg. But, and this is crucial, sometimes the body's initial compensation can keep the blood pressure looking normal or near normal for a short time. You can't rely on BP alone, especially early on.
And urine output?
Almost always significantly decreased. That's oliguria. Or it might stop altogether in urea. Kidneys aren't getting perfused.
Okay. And in the hospital, what tests get run right away?
Standard initial labs would include a CBC, complete blood count, a basic metabolic panel, Chem7 to check electrolytes, kidney function, definitely that lactate level we talked about, coagulation studies to see how the blood is clotting, blood cultures if infection is suspected, and an arterial blood gas, an ABG, to check oxygen levels and acid status directly. Others depend on the suspected cause.
Got it. Now, managing shock. The sources mention the ABCDs. Can we walk through those?
Sure. It's a standard approach to critically ill patients. A is for airway.
Making sure they can breathe. Might need a breathing tube.
Potentially, yeah. If they can't protect their own airway due to altered mental status, or if breathing is failing, intubation is necessary. B is breathing.
Supporting their breathing.
Right. Often means mechanical ventilation. And sedation is important too because struggling to breathe uses up a huge amount of oxygen, which is the last thing someone in shock can afford. We need to decrease that work of breathing.
Okay. C is circulation. This is about fluids.
Primarily, yes. Giving intravenous fluids, usually isotonic crystalloids like normal saline or lactated ringers. Often, large volumes are needed quickly, multiple liters.
How do you know how much to give?
It's titrated.
Yeah.
You watch specific targets, maybe aiming for a certain central venous pressure or seeing urine output pick up to at least 0.5 milliliter per kilogram per hour, or seeing the heart rate come down, and you give fluids until you see improvement or reach those goals.
D is delivery of oxygen.
This loops back to monitoring things like lactate. Seeing lactate levels fall is a good sign that oxygen delivery to the tissues is getting better.
And finally, E, endpoint of resuscitation.
These are the overall goals you're aiming for to say, okay, we've successfully resuscitated this person for now. Things like adequate urine output, a mean arterial pressure, MAP, usually between 65 and 90 millimol Hg, and good central venous oxygen saturation, often over 70%. Basically signs the body is no longer in that profound oxygen debt.
Okay, that framework makes sense. But now, the really interesting part. How these rules change depending on which type of shock we're dealing with. This is where the specifics matter hugely.
They really do. Let's dive into hypovolemic shock first.
Yeah.
The low volume type.
Caused by losing blood or fluids.
Exactly. Hemorrhagic from bleeding is probably the most common cause you think of. Major trauma, GI bleeds, ruptured aneurysms, postpartum hemorrhage. Lots of possibilities.
And non-hemorrhagic.
Things like severe vomiting or diarrhea, pancreatitis where fluid leaks out of vessels, big burns, losing plasma, even diabetic ketoacidosis where high sugar makes you urinate excessively. Anything that severely depletes the body's fluid volume.
So the mechanism is just not enough fluid in the system.
Right. That loss of volume triggers all those compensatory responses we discussed. Faster heart rate, clamp down blood vessels, high SVR, eventually low blood pressure and low cardiac output. The heart tries to pump faster, the vessels squeeze tighter, the body holds on to water.
What does the patient look like? What are the signs?
Tachycardia, fast heart rate. Hypotension, low blood pressure. Low urine output. Because of the vasoconstriction, their skin is typically pale, cool, maybe clammy. Capillary refill is slow press on a fingernail. It takes more than 2 seconds for the pain color to return. They look dehydrated, poor skin turgor, dry mouth, and altered mental status from reduced brain perfusion. Usually, though, not severe breathing difficulty directly from the shock itself.
And key physical exam findings.
That pale, cool, clammy skin is often the first clue. Maybe mottling, slow cap refill, dry mucous membranes. Importantly, their neck veins will likely be flat, not distended, because there's low volume returning to the heart. And remember, tachycardia is usually the very first vital sign to change.
You mentioned something interesting earlier about how much blood you can lose before it's obvious.
Yeah, the body is surprisingly good at compensating initially. Lose less than 15% of your blood volume, your pulse and blood pressure might look totally normal. Lose 15–30%, you'll likely see the heart rate go up over 100, but the blood pressure might still hold above 100. Systolic. It's when you get to 30–40% loss that things get really obvious. Fast heart rate, systolic BP drops below 100, confusion sets in, urine output tanks, and over 40% loss. Severe shock, lethargy, basically no urine output. It's a rapid decline once compensation fails.
How is it diagnosed definitively?
It's that combination of clinical signs plus the hemodynamic picture. High SVR, low blood pressure, low cardiac output, low filling pressures in the heart like CVP and pulmonary capillary wedge pressure. Blood tests might initially show high hemoglobin hematocrit if it's dehydration, but in hemorrhage, a low H&H is actually a late sign after the body is trying to dilute the remaining blood with other fluids.
Management then beyond ABCDEs. Priority 1.
Volume, volume, volume. Get large IVs in or a central line, start pouring in crystalloid fluids, normal saline lactated ringers. But critically, if it's hemorrhagic shock, blood products are way better. Packed red blood cells are key.
And you monitor how they respond.
Constantly. Watching blood pressure, urine output, mental status, looking for signs of fluid overload like edema. You also had to find and stop the bleeding or fluid loss. That's paramount. Control the source. Might need surgery.
Okay, now the big question here. Vasopressors. Drugs that squeeze blood vessels.
Generally, no. This is a huge point. In pure hypovolemic shock, the problem is an empty tank. Squeezing the pipes harder doesn't help. It can actually worsen blood flow to tissues. So vasopressors are usually avoided unless there's absolutely no response to massive volume resuscitation, which is rare. Fill the tank first.
Got it. Big contrast coming up, I suspect. Let's talk cardiogenic shock.
Right. Here, the pump itself is the problem. Decreased cardiac output, tissues aren't getting oxygen, but the fluid volume is adequate, maybe even high. The defining feature is low blood pressure with a high pulmonary capillary wedge pressure, usually over 15 mmHg. That high wedge pressure tells you fluid is backing up because the heart can't pump it forward.
So hemodynamics, low CO, high SVR as the body tries to compensate, low BP, and that high wedge pressure.
Exactly. It's a failing pump causing a traffic jam behind it.
Management must be totally different. What's the priority?
Treat the cause. If it's a heart attack blocking a coronary artery, you need to open that artery ASE. Angioplasty, PCI, bypass surgery, CABG, maybe clot-busting drugs. Restore blood flow to the damaged heart muscle. And crucially, avoid drugs like beta blockers that would further weaken the heart's pumping.
And fluids. This is the big one.
Right. Total opposite of hypovolemic shock. You avoid aggressive 5E fluids here. Giving lots of fluid would just overwhelm the failing heart even more, push more fluid into the lungs, causing terrible pulmonary edema. Cardiogenic shock is really the only type where large fluid volumes are generally not given. You might even need diuretics to remove fluid.
So if not fluids, what do you use to support blood pressure and circulation?
This is where vasopressors and inotropes come in. Inotropes are drugs that help the heart muscle contract more forcefully. Vasopressors squeeze blood vessels to raise blood pressure. Often, you need both.
Which ones?
If the blood pressure is really low, norepinephrine is often the first choice. It provides strong vasoconstriction plus some support for heart contractility. If the blood pressure isn't quite as critical, but the heart needs help pumping, dobutamine might be the initial choice. It's primarily an inotrope. And there are others like milrinone if the first options aren't enough. The goal is to support the heart and maintain perfusion without overloading it with fluid.
Makes sense. Okay, third type, obstructive shock, the roadblock type.
Yep, something is physically blocking blood flow into or out of the heart. It could be intrinsic, like a clot inside a major vessel, or extrinsic, like pressure from outside the heart squeezing it.
How does this look compared to the others?
It can share some features with hypovolemic shock, low BP, cool clammy skin, fast heart rate. But the key differentiator, similar to cardiogenic shock, is often distended neck veins increase jugular venous distension, JVD. That tells you blood is backing up because it can't get through the obstruction.
Hemodynamics. What are the pressures doing?
Pulmonary capillary wedge pressure is usually low or normal, unless the obstruction is something like cardiac tamponade where the pressure builds up around the heart itself. Then PCWP can be high. Cardiac output might be normal or even high initially, but it can't get delivered effectively. SVR will likely be high as the body tries to compensate for the falling effective circulation.
What are some classic causes? This sounds dramatic.
It often is.
Yeah.
A massive pulmonary embolism, PE is a prime example. A huge clot blocks the pulmonary artery. Patients get cyanotic, blue, tachycardic, hypotensive, very dangerous.
Okay, what else?
Pericardial tamponade, blood or fluid fills the sac around the heart, squeezing it so it can't fill. That gives you Beck's triad, muffled heart sounds, low blood pressure, and those distended neck veins.
Right.
Another is tension pneumothorax. Air gets trapped in the chest cavity under pressure, collapsing the lung and pushing the heart and great vessels over. You'll hear decreased breath sounds on one side, see the trachea shift away, maybe feel air crackling under the skin, and again, distended neck veins. And even sometimes of aortic dissection, where the wall of the aorta tears can cause obstruction if the tear affects blood flow near the heart.
Wow. So management here seems obvious. Remove the obstruction.
Exactly. That's the absolute priority. While you give supportive care, oxygen, maybe some fluids consciously, sometimes inotropes, the definitive treatment is fixing the underlying mechanical problem. For a massive PE, it's anticoagulants, thrombolytics, clot busters, or even surgery to remove the clot, embolectomy.
For tamponade,
Pericardiocentesis, draining the fluid from around the heart with a needle.
tension pneumothorax,
Immediate needle decompression to let the trapped air out, followed by a chest tube.
and aortic dissection.
Usually requires emergency surgery. The key is rapid diagnosis and fixing the blockage.
Okay, that leaves the last and maybe most complex category, distributive shock.
Right. This one's fundamentally different because the primary problem isn't volume loss, pump failure, or obstruction. It's massive vasodilation. The blood vessels become too relaxed, losing their tone.
So the pipes are too wide?
Exactly. Blood pools in the periphery, pressure drops, and even if the heart is pumping well initially, blood isn't getting back to the heart effectively or being distributed properly to vital organs. The hallmark is usually low SVR, often high initial cardiac output as the heart tries to compensate, and low filling pressures like PCWP. It's a distribution problem.
And the main types under this umbrella?
Most common by far is septic shock, caused by overwhelming infection. Then anaphylactic shock from severe allergic reactions, neurogenic shock from spinal cord injuries disrupting nerve signals to blood vessels, and endocrine shock, like an adrenal crisis.
Let's start with septic shock. How does that develop?
It usually starts with an infection leading to SIRS, systemic inflammatory response syndrome. That's defined by things like abnormal temperature, heart rate, breathing rate, or white blood cell count. If that progresses to cause organ dysfunction, it's called sepsis. And if sepsis leads to persistent low blood pressure despite getting adequate fluids, that's septic shock.
What does septic shock look like?
Clinically, you see low cardiac filling pressures, and that hallmark, decreased SVR. But here's that tricky part. Early on, in what's called hyperdynamic or warm shock, the cardiac output is often high. The heart beats fast and hard trying to compensate for the wide-open vessels. That's why the skin might be warm and flushed initially, unlike other shock types.
Management is pretty specific here, right? The 3-hour bundle.
Yes, time is critical. Within the first 3 hours, ideally, get blood cultures before antibiotics if possible. Measure lactate, give broad-spectrum antibiotics right away, and administer a big bolus of crystalloid fluids, usually 30 milliliters per kilogram if they're hypotensive or have a high lactate.
And if fluids aren't enough to bring the pressure up?
Then you move to vasopressors. Norepinephrine is typically the first choice to squeeze those dilated vessels and maintain a mean arterial pressure, MAP, above 65 mmHg, ensuring vital organs get perfused. Okay. Next, anaphylactic shock, the severe allergic reaction.
Right. Triggered by allergens, insect stings, foods, drugs, 5E contrast. It's rapid, usually within an hour of exposure. An IgE-mediated immune system explosion.
Signs, besides the obvious potential trigger.
It often starts with itching, hives, angioedema, swelling, especially face, lips, tongue. But it can rapidly progress to respiratory distress, wheezing, stridor, noisy breathing, feeling like your throat is closing, hoarseness. That laryngeal edema is life-threatening.
Management is epinephrine, right? Fast.
Absolutely critical. First line is intramuscular epinephrine like an EpiPen injection. Give it immediately. Repeat every 5–10 minutes if needed. If they're in full cardiovascular collapse, IV epinephrine might be used.
Anything else? Airway management is key, maybe intubation. Antihistamines help block the reaction. 4V fluids are important too. And crucially, patients need observation for at least 4–6 hours afterwards.
Why so long?
Because of the biphasic reaction.
Yeah.
Symptoms can actually come back hours after the initial reaction seems to resolve in up to 20% of cases. You can't send them home too early.
Good point. Okay, neurogenic shock, spinal cord injury.
Usually, yes. Acute spinal cord injury, sometimes regional anesthesia. It disrupts the sympathetic nervous system signals that normally keep blood vessels toned. You get unopposed parasympathetic vagal tone.
Which leads to?
A weird combination.
Yeah.
Bradycardia, slow heart rate, and hypotension. Plus, because the sympathetic tone is lost, the skin is often warm and dry and not cool and clammy. You might see a wide pulse pressure.
Management.
Fluids are usually given first, then vasopressors are often needed to counteract the vasodilation and support heart rate. Sometimes corticosteroids are used too.
And lastly, endocrine shock, adrenal crisis.
Yeah, like Addisonian crisis, where the adrenal glands aren't producing enough cortisol. The key management point here is giving hydrocortisone IV immediately. These patients often won't respond adequately to just fluids and pressors until they get steroids.
Wow. Okay. We have covered a lot of ground, from just the word shock to 4 very distinct medical emergencies.
It's quite a journey, isn't it? Hypovolemic, cardiogenic, obstructive, distributive, each with its own story, its own physiology.
And the treatments are so specific. Fluids for one, definitely not for another. Pressors needed here, avoided there. It really drives home how crucial that initial diagnosis is.
Absolutely. That's the core insight, I think. How a similar sign, like low blood pressure, can hide completely different problems underneath. You have to dig deeper, understand the mechanism, because the management hinges entirely on getting that right. It really shows the power of knowing the details.
So as we wrap up, maybe something for you to think about. How does understanding these deep distinctions, these sometimes counterintuitive differences, change how you might view critical situations? Or even just how complex systems like the human body work? Where else do seemingly similar things on the surface hide really critical differences underneath?
That's a great thought to leave with. It applies to so much more than just medicine, doesn't it? Looking beyond the surface.
Definitely something to ponder. Thanks for joining us on this deep dive.